Good afternoon, everybody, or good morning, depending on where you're joining us from. Welcome and thank you for attending today's webinar, Overdose in Australia. We'll be presenting to you some findings from the 2025 Australia's Annual Overdose Report. My name is Rita Bryan. I'm the Senior Workforce Development Officer at Penington Institute. I'll be facilitating today's session for you. For those who don't know, Penington Institute is a not-for-profit organisation. We work to support solutions to help communities and frontline services reduce drug-related harm, which includes unregulated drugs, harms from alcohol, as well as pharmaceutical medicines. And we aim to make public policy work for the people, not against them, and we do this by embedding harm minimisation as a cornerstone of effective public health policy. Before we start, I'd like to just acknowledge that I'm joining today from Wurundjeri Woiwurrung country, and I'd like to acknowledge the traditional custodians of the lands where I live and work and pay my respect to elders past and present. I'd also like to acknowledge the Indigenous people of the various lands where you're joining from today. Certainly welcome any First Nations people who are in attendance on the webinar. And just take a moment to show respect for all the unique cultures and languages of the diverse communities that make up this lovely world that we inhabit. So as most of you should or probably do know, yesterday was International Overdose Awareness Day, which is the world's largest campaign to end overdose, convened by Penington Institute since 2012. Overdose Day is now observed on the 31st of August every year by communities in more than 40 countries worldwide. Yet we're still seeing unacceptable rates of overdose globally. And Overdose Day, I guess, is a really important time for us all to be able to collectively come together and not just raise awareness about overdose prevention and responses, but also commemorate lives that we've lost, also acknowledging people who've been injured, harmed, or affected in any other way by overdose. But it's also a really valuable and important opportunity for us to come together and make a unified call to decision makers for more effective evidence-based public health responses to the ongoing global overdose crisis. And just with that in mind, I just want to acknowledge that talking about overdose can trigger an emotional response for some people, especially at this time of year. And so I'd like to acknowledge everyone in our communities who have been affected by overdose, whether it's at work, whether it's in your homes or schools or communities, and just encourage you to be mindful of your own safety and well-being and everybody else around you, especially at this time. So, as mentioned, today we will be presenting to you the data from the 2025 Australia's Annual Overdose Report, which is a comprehensive snapshot of national overdose data rates and trends over the last decade or so. This year's report presents available data on fatal and non-fatal overdoses for the 2023 calendar year. And as you're soon going to learn, Australia has continued to record more than 2,000 overdose deaths for 10 consecutive years. That's 6 Australians every day, or as noted, a Boeing 737 plane full of passengers every month. It's a really sobering statistic, considering most, if not all, overdose deaths are avoidable. And as it has for many years, the national overdose toll continues to exceed the road toll, as I'm sure you'll hear about today, as it's done for several years, yet we sort of have failed to see suitable action to reduce this tragic and preventable trend that's impacting so many Australians. And the need for action remains as strong, as urgent as ever, I'm sure you'll take away from today's session. So in terms of the order of proceedings, before presenting some of the key findings from the report, I'm really delighted to also be able to have Dr Hester Wilson with us. Dr Wilson's the chair of the Royal Australian College of General Practitioners Addiction Special Interest Group. Sorry, I know I got the word wrong there, Hester. And in just a short moment, Dr. Wilson will be providing a very special address on the crucial role that general practitioners can help to play in overdose prevention and response. Then we'll move on to Dr. Jake Dizard, who many of you will know as our Director of Research and Policy, and Jake will provide an overview of the data presented in this year's report. And then after that, we'll hopefully have some time for questions and a bit of a discussion with both presenters. So I just want to remind you that the webinar will be recorded today. It'll be made available online after the session. The usual Zoom chat function is disabled, so we encourage you to reach out with questions via the Q&A button that you can see on your screen, and we'll get to as many of those that we can at the end. And that's it from me for now. Without any further ado, I'm absolutely delighted, as I said, to introduce you properly to our guest presenter, Dr. Hester Wilson. Dr. Wilson's the Chief Addiction Specialist for New South Wales Health, Clinical Director for Murrumbidgee Drug and Alcohol, and a GP in private practice in Sydney. As mentioned, she chairs the RACGP Addiction Specific Interest Group, and a clinician with many years of clinical and teaching experience. Dr. Wilson's also currently undertaking a PhD focused on GPs' experiences of patients with chronic pain and prescription opioid dependence, which is clearly highly relevant and a really great. We're really looking forward to hearing from you today to open up the session. So whenever you're ready, I will hand over to you, Hester.
Thank you so much, Rita. Just going to try and share the screen. Have you got the right screen?
We do.
Fantastic. That's great. Look, thank you so much for inviting me to be part of this and this important day after the day of overdose awareness, and every day should be Overdose Awareness Day. I just got to make sure that I can, yep. So first of all, I do want to do an acknowledgement of country as well and show my respect to elders past, present and emerging, and extend that the respect to any First Nations peoples with us today. And just flag, I'm calling in from Gadigal land, Gadigal on the Eora Nation. I also want to recognise those with lived and living experience, people in our communities who have experienced mental health concerns, drug and alcohol use, and also suicide, and those who love and care for them. I recognise those that have been lost early and the impact on this on their families, carers and communities. And as a healthcare worker, I recognise the brave and generous contributions that people with lived and lived experience help us, both as the people that we see, but also as peer workers or lived and living experience workers, to continually shape and provide quality care. So first of all, I'm going to talk a little bit about GPs. Now, first up, I just want to flag, we are a really diverse group. So you have people like myself who are deeply engaged in harm reduction. You know, I'm the chair of the specific interest group in addiction in the College of GPs. I've worked in low threshold and outreach services for many years. So this is my space. But for some of my colleagues, it's not so much. So there's a wide range of expertise in harm reduction, harm minimisation, and interest in this area as well. But what is core to all of us in general practice is that we're trained to provide holistic care that takes into account the person's physical, emotional, spiritual, social aspects. And we're aware how complex this can be. We see people over time and we are able to develop really strong therapeutic alliances that are deeply based in trust. There are 40,000 GPs around Australia and 3/4 of them work full time. And they work in over 8,000 settings. So all over this country, we have GPs working. I do note that the rate is about 110 GPs to every 100,000 people in the community, and in some areas, and that's particularly rural, remote and inland areas, the levels are much lower, and we're seeing the rates of GP per 100,000 actually decreasing. We see 9 out of 10 people every year. 71% of us, almost 3/4 of us, say that in my top 10 of the conditions I see are people presenting with distress or mental health concerns, and that includes drug and alcohol. And on average, we see each person for about 19 minutes. Now, some of us will see patients that might just need a vaccination or something quick and short, or they may be, like myself, people who do much longer consults. But the reality is that 19 minutes isn't an awful lot of time. And the way our system is set up, it makes it difficult to do longer, more in-depth, time-consuming consultations that you need to assist people that are presenting with complex issues. We prescribe high-risk medicines, and we see lots of people with chronic pain, mental health issues, and multiple health conditions. We also see people who use drugs, but we may not always know about that. I think I also just want to mention that we're a diverse group. Culturally, nearly half of us are international medical graduates and have a broad range of cultural backgrounds, religious backgrounds, and all of those actually impact the way we do our work. And one of the reasons that we choose general practice is because of the independence that it gives us to work in the way that fits our values. Almost 1 in 6 are older than 65, so we're on the way to saying goodbye and going off into retirement. Hopefully we will be able to recruit more GPs, but it is an issue at the moment in terms of GP numbers. So just a little bit, and this is kind of what my PhD is looking at, so to try and fit this into a very short presentation is a challenge. But basically, as I said, we prescribe high-risk medications, and we're aware of the complexities of people's lives. And at times, those complexities become much more important than the medications we're prescribing. So trying to manage these complexities and support people to manage that in their lives is complex. As a group, we are worried and anxious about high-risk medicines. And we find conversations and helping people to change high-risk medicines quite difficult, particularly if they've been started by a specialist. It can be quite difficult to shift that. And there's a strong sense of feeling unsupported by specialists, and that includes mental health, drug and alcohol, cardiologists, respiratory physicians, the full gamut. And as I said before, sometimes it can be tricky for us to ask about drug use, and the reasons are complex there. And it's very easy for people to say, oh, that's just GP stigmatizing. And yeah, look, it is part of the story, but there's a whole story there around, I don't want my patients to feel stigmatized. I don't want to put this in their notes so that somebody else will stigmatize them. This is a tricky conversation to have. This may impact my therapeutic alliance. So it's not an easy thing to do. So here we are. We see 9 out of 10 of the community. And we are ideally placed. I love this word, and I see it a lot in the literature. GPs are ideally placed. Yes, we are. We're ideally placed to do just about everything. Just like our pharmacy colleagues, we're all ideally placed. But it's not that simple. Now, this is from the Health of the Nation 2024, and top of the line there was the issues that GPs have just feeling burnt out, overwhelmed and burnt out, feeling undervalued in our community, trying to deal with rapidly changing regulatory and policy environments, difficulty managing their workload. And another really important one, as I've mentioned before, was access to care for other specialists for our patients. So when you're feeling like this, it's really hard to start doing yet another activity when there's so much on your plate to start with. The issue of time, as I've mentioned before, is a tricky one. Feeling like you've got the skills, feeling like it is part of your role. And I should flag that this is changing, and there is some generational change there as well, that older GPs potentially are not quite so interested in obtaining new skills and being involved in this area, and their attitudes towards drug use might be a little bit different. Younger doctors are more open to this, but they don't have the skills always. So it's around how we can build that and how we can provide support. The RACGP did a really extensive education program back during COVID with a really carefully thought out program based on adult education that over 3,000 GPs took part in, and really very strong feedback that it was hugely successful and helped them to feel more confident and be able to have these conversations more. One of the things I wanted to mark here was that we paid the GPs to attend, and this was an important part in a group of people that feel undervalued, to have their time valued. And it wasn't a huge amount of money, but it's around valuing your time and really getting some skin in the game around continuing and doing this education, and that we valued their time and we valued their skills and we wanted to increase them. One of the things that Jake asked me was which are the policies that we should expand? Now, of course, ongoing education is core, and you've got to keep doing that. You've got to, and short, sharp things that just help people tweak what they're doing, that feed into their experience and their patients is incredibly important. Promoting this overdose as preventable and life-saving treatments that are available is incredibly important. And I do want to make a flag for the little yellow square that I've got there, which is the Opioid Safety Toolkit that was put together by the Monash Addiction Centre. A great website. It is human-facing or patient-facing, but also for practitioners, and has great tools. And it really gives really gentle, easy ways to start talking about this tricky area of high-risk medications, particularly opioids, for yourself or for a family member. And its whole emphasis around helping people be safe, helping people get the best care that they can to have the best possible lives. Real-time prescription monitoring, or SafeScript or QScript, is available in all jurisdictions around Australia, and it has been really positive. I know there have been concerns about the unintended consequences of SafeScript, but certainly the feedback that I get from my colleagues is it's excellent, and that it helps them to be confident that what they're prescribing is correct and they're not going to harm their patients, and helps to trigger conversations around safety, which is really important. One thing that would be good is to have a SafeScript that is Australia-wide, because at the moment I have to kind of log on to different SafeScripts depending on where my patient is, and that's time consuming. So it would be great to have a national one. I don't know how close that is to possibilities, but that would be great. The other thing is the intranasal naloxone is not part of the prescriber's bag. Now, it is available for free over the counter at pharmacies, but to actually have it as something that is in that list of the medications that you can get to have in your prescriber's bag, so for nurse practitioners or doctors, to have it there, I think would be a really great and quite easy win. The other thing is support for GPs, understanding that you may have someone that has all the skills but doesn't have the time, or you may have someone that doesn't have the skills and is super busy. Support services that help GPs undertake this work. Navigators to help people navigate services and to help GPs as well, and peer services. I cannot tell you how enriched my working life is and how more successful my interactions are with the people that I see, having peer workers in the picture. They're able to have conversations with people in ways that I, as a doctor, I can't. And that's where their gold is, and they are just amazing. And I'd love to see ways that we could actually support them to work with GPs and support GPs to work with them. The other thing to remember is in general practice, we see families. And so we have this opportunity to have conversations with families. And that is quite often what happens, is that I will see a family member who is concerned about a loved one, and how we have the skills to support family members to have those conversations. It does come back to money to some extent. We know that primary care is highly cost effective, prevention is highly cost effective, and yet what we're seeing in Australia is overall the rates of funding for primary care are going down. We've got bigger populations, bigger need, and the funding is not keeping pace with that. So I did want to make a point about and really looking at overdose. It's important to acknowledge that unintentional overdose is one, but so is suicide, and just flag the tragedy that is that trajectory for someone who feels so poorly. Their mental health is so poor, their situation is so poor, that dying by suicide seems like a rational choice, and we need to continue doing work in that space to support people to access care. The other thing about drug use, once again, nobody who is using wants to come to harm. Nobody uses drugs to become addicted. There's lots of reasons why people do, but they don't do it for that. And I do note And Jake will go into the numbers, but I am encouraged that the numbers have actually decreased. It's still not acceptable. There's still more work to do. And us in general practice do have a role. And it could be a really, the 30-second conversation. But it's how do you allow that to happen in an environment where there are so many competing demands? And how do we make this easy? How do we support this and give GPs the skills that they need? It's totally acknowledging that there are many of us that are doing this already and do it well. And this is just talking to some of my colleagues, patient misconceptions around overdose risk. And in talking to my colleagues, this was stuff that they'd heard from their patients as well. Oh, well, I'm on a prescription medicine, so that's safe. Oh, this is a prescription medicine that I was given. It's been in my bathroom cabinet, so it's safe for me to give to someone else because it worked well for me. Mixing is okay because they're all prescription medicines, or alcohol's not going to be a problem because it's not a prescription medicine. Or I'm using this for a medicinal purpose and so forth, I'm not at risk. All of those are just not true, unfortunately. The other one that people will say is, oh, it's only if you inject that you're at risk. And the other one, which is so important in terms of ensuring that people use the EpiPen of overdose prevention, that's the naloxone in either form, is if I call for help, I'll get into trouble. Really strong messaging around, no, we want to make sure that everybody survives and call for help, because just giving the naloxone quite often is not enough. It'll save someone short term, but they need more help after you've done that. The other thing is that we live in this world of emerging change, and certainly I've got the picture there that many of you would have seen of the nitazene infused vape liquid that was found by police not that long ago in southwest Sydney. And we have a group of young people who were using what they thought were cannabinoids in their vapes, and it turned out to be nitazenes. Now, nitazenes are a class of drug. They can be short-acting, long-acting. They can be highly potent or not that potent. But really, this is an issue because people don't know what they're getting. And we've seen overdoses as a result of this, and we've seen people develop dependence. At the moment, nitazenes are really quite rare. And we've been very fortunate not to have gone down the same trajectory as North America with the fentanyl crisis. But it's always there. So it's something that we do need to be alert around and really thinking around. And then there's lots of work going on in this space around early warning signs and working effectively to get those messages out so that people can be safe with their using. The other thing is people will use what they can get. So they will use multiple options, and they mix pharmaceuticals with the non-pharmaceuticals, and it's a tricky thing because, once again, coming back to those myths that somehow this is safer. And I totally understand, with heroin injected, fast onset, it's high risk, and it figures high in the overdose rates. But so are the pharmaceuticals, and the fact that they come in a shiny box and look like they're safe, they aren't. They are high-risk medicines. And we're seeing a group of people who are getting older, and sadly, as we get older, the way our bodies work, the way our livers respond, our kidneys respond, the way our heart and lungs can respond to a particular active substance, whether it be a pharmaceutical or an informal substance, changes as you get old. And you have other medical problems, you have other medications, and so our risk actually increases. I wanted to, before I ended, just to flag, just thinking about myself as a clinician, and going back to what Rita said around the impact that overdoses have on us. And over the years that I've worked in this area, people that I've consulted with have died of overdose. I remember their faces. I remember their names. I remember the sound of their voice. I remember their incredible uniqueness as human beings. And I grieve for every one of them. And I really want us to be able to change this because it is preventable. And involving GPs in this is important. Thank you so much.
Thank you, Hester. What an impassioned and wonderful presentation. Thank you so much. And for pointing out specifically, overdose isn't just a problem for people who inject drugs or use illegal, unregulated substances. It's far more widespread than that. But 110 GPs to 100,000 people, not including, sort of limitations regionally. No wonder they're a sort of burnt out and retiring profession. I'll encourage everybody to post questions for Dr. Wilson in the chat if you have anything to follow up. And while you're contemplating your questions and discussion, I will introduce Dr. Jake Dizard. As mentioned, Jake's going to present our findings from the 2025 annual overdose report. Jake is our Director of Research, is the Director of Research and Policy at Penington Institute, and his current area of interest and focus, I should say, include cannabis policy, global drug policy, and overdose prevention and responses. Jake's work on drug policy is really informed by his extensive background in human rights and political science. And during his almost 2 decades in non-government, not-for-profit and academia sectors, Jake really strives to produce clear analyses that can contribute not just to policy reform, but to community-based advocacy for systems change, which is kind of why we're all coming together today, right? So Jake, when you're ready, I'll let you take over. And welcome you to the floor.
Thank you, Rita.
Are seeing a slightly different screen to before, but you're welcome to continue from that screen.
Okay, can you see the slideshow now?
Yes, perfect.
Great, thanks so much. So thanks so much, Rita, and thanks also to Hester for joining us today and for the interesting and very thought-provoking presentation. So my role today is to go over some of the principal findings from this year's edition of Australia's annual overdose report. But before starting, I would also like to acknowledge the Wurundjeri Woi-wurrung people as the traditional custodians of the stolen land on which I live and am presenting from today, and extend that respect to any First Nations people joining us today. And I'd also like to join Hester in recognizing people with lived and living experience. And on the occasion of International Overdose Awareness Day, all the family and friends of people who have been lost to overdose in the past, and all the people, especially on the front lines, but in general, working to prevent overdose in the future. Okay, so just to get some basics out of the way, the report presents data on drug-induced deaths reported between 2001 and 2023. So drug-induced deaths, which is kind of a jargony phrase, are those caused directly by drug use, intentionally or unintentionally. And most of our focus is on unintentional deaths, which comprise about 80% of the total. But as Hester alluded to, it is important to also recognize the roughly 18% of drug-induced deaths that are intentional or suicide in nature. So the fatal overdose data in this report are based on cause of death information, which is certified by doctors or coroners, collected by state and territory governments, and validated and compiled by our esteemed partners at the Australian Bureau of Statistics. So the report covers data regarding also non-fatal overdoses, and both the fatal and non-fatal sections include a range of drugs, so pharmaceutical and prescribed drugs, illicit drugs, and alcohol, which is a psychoactive substance that can produce a range of harms, including death, just as any other drug. All right, let's get into the data. I describe the overall story as mixed. Under the surface, there are some encouraging signs, but at the highest level, what we see is a continuation of an ongoing epidemic of preventable death. So, headline findings. As Rita mentioned, this is the 10th year in a row that we see more than 2,000 drug-induced deaths recorded, and that adds to the toll of over 42,000 fatal overdoses in Australia this century. So the total number declined by about 6% from 2022. And that'll be probably more like 4% once revisions to the data are complete. But regardless, that is still an average of over 6 Australians dying every single day. So we'll see that it looks like we might be past the most recent peak in terms of the rate of overdose, but the toll is still, the word Rita used, unacceptably high. This is a massive scale tragedy, and the urgency for action remains as strong as ever. So just to maintain the high level view for a second, we can get some perspective by comparing the overdose toll to the road toll. And I would note that the road toll has prompted significant government action. We have Vision Zero, we have a national road safety strategy, all attempting to get the road toll down as low as possible. But we do not have a national overdose prevention strategy that would demonstrate the equivalent urgency and hopefully help funnel the necessary resources into overdose prevention. So drug-induced deaths in Australia surpassed the number of deaths from road traffic accidents in 2008. And since 2014, unintentional drug-induced deaths alone have been higher than the number from road traffic accidents. And in fact, that discrepancy, the gap, has grown over time. So the increase in the number of unintentional drug-induced deaths has also exceeded population growth. This is not just a question of numbers as the country gets bigger, it's an issue of rates as well. So since 2001, the sort of beginning of the reference period, the population of Australia has increased by 38%, including me as a relatively recent migrant, while the number of unintentional drug-induced deaths has grown by 80%, so almost doubled. All right, now let's start looking in a bit more detail at changing patterns over time, focusing on unintentional overdose. So what this chart shows is that since 2001, there's been a notable shift in the age distribution. So in 2001, about 50% of unintentional overdoses occurred in people under 40, 39 or under. But by 2023, that was closer to 25% share. Meanwhile, the share of overdose deaths accounted for by people in their 40s, and especially in their 50s and 60s, has risen quite substantially over time. So in raw numbers, for instance, you can see in the chart that on the right side that the numbers for people in their 40s, 50s, and 60s, those percentages are quite high compared to 2001. And in raw numbers, it's the same. So deaths among people in their 50s, for instance, have quadrupled in number since 2001. So there's a shifting age distribution. So in contrast, deaths among people 29 and below have decreased over time by about a third in number. So what this illustrates, along with just that shifting age distribution, is that overdose is dynamic. It's subject to a lot of shift over time, and that might contradict people's image of who experiences overdose. So whatever image you have in your head of, oh, this is the typical person, or these are the few types, it's not likely to be true. And even if it is sort of true in some broad sense, it will be wrong eventually because things change. Now, one pattern I should note that is unfortunately quite stable over time is the vast discrepancy in the overdose rate between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. So in 2023, the rate of unintentional drug-induced death among Indigenous people was 22.5 per 100,000 population, compared with 5.7 for non-Indigenous people, so almost 4 times the rate. This has been persistent for over 20 years, and fatal overdose rates for Indigenous people actually accelerated in the 2010s, like after 2009. And as this chart indicates, and notably in the 5 years to 2023, so 2019 to 2023, the rate of unintentional drug-induced death was higher for Indigenous people in every drug type category, not just overall, but in every single category that the data shows us, with particularly stark differences in the stimulant and opioid categories. Now, to stick with drug type analysis, so as is typically the case, opioids were the most common drug type associated with unintentional drug-induced death in 2023, and they contributed to almost half, about 43% of these deaths. However, and here's the first bit of slightly encouraging news, the 776 deaths involving opioid in 2023 marks a decline from 2022 when there were 950, and an even sharper decline from the peak in 2018 when there were over 1,100 opioid deaths. The other thing worth highlighting in this chart on the screen is the position of stimulants as the second most common drug type contributing to overdose deaths. So benzodiazepines had previously been second place, dating back to the beginning of the time series, but the combination of a drop in benzodiazepine-involved deaths and a stubborn persistence in stimulant-involved deaths has changed the positioning. So this chart might be a little bit busy to get into, hyper-detailed analysis, but it does reveal some evident trends in the drug types contributing to overdose deaths. So, as is probably obvious, the number of unintentional overdoses involving most drug types rose sharply in the mid to late 2010s. I mean, you can see that the lines go up in almost every category, peaking around 2016 to 2018 for most drug types. Since then, most types have stabilized, and in a few cases, they've declined. So most obvious are the top two lines, the dark blue and light blue, which are opioids at the top and benzodiazepines next, which seem at this point, I think we can say, to be showing a somewhat of a trend of decline. Contrast that to stimulants, the red line, which have plateaued at a much higher level than the 2000s. And I'd also note, by the way, that cocaine, which is the line at the bottom, is coded separately in our data, but if you include it with stimulants, which is kind of makes sense in a lot of ways, the rising contribution of stimulants to unintentional overdose is even more pronounced. Another way to observe the change with stimulants over time is just to look at the share of unintentional overdoses involving stimulants in 2001 compared to 2023. What you see is a six-fold rise in that share. So again, and that would be even higher if you included cocaine. So 2001, 5.4% of fatal unintentional overdoses involved stimulants, and now that's up to fully, almost just below 1/3 in 2023. And I do want to mention a caveat that I'll mention again at the end, and that Hester spoke about too. Most overdose deaths involve more than one drug. And so this is certainly true for stimulant-related overdoses. Of the nearly 2,000 unintentional deaths involving stimulants between 2019 and 2023, only 47, which is about 2.5%, had stimulants as the sole drug type, right? So in general, we're talking about polysubstance deaths, and that's sort of that's the case across most drug types. So to dig into changing trends just a bit more, we can break down the opioids drug type into subgroups. So what you see in the chart is that since 2001, the number of unintentional deaths involving the various opioid types have all risen, with heroin the foremost contributor. As you can see, it went from 101 deaths involving heroin in 2001 to 347 in 2023, although that's down from the peak, as I mentioned. And a sharp rise is also visible in the third group from the left, the synthetic opioids. Now, if we look in more detail at the trends across these subgroups, you see some interesting variation. So again, everything rose dramatically for a while in the 2010s. But if you look at the light blue line, there's a sharp drop. Whereas other opioid types have stabilized, or in the case of heroin, which is the dark blue line, spiked up and down. So that light blue line is natural and semi-synthetic opioids, which include some of the most familiar ones, like codeine and oxycodone. So it's plausible that changes to policy have played a role there. There have been, as Hester spoke about, some changes to prescription rates for oxycodone, certainly. And also codeine was rescheduled to move from a Schedule 3 drug, I believe, that you could access over the counter, to a Schedule 4 drug in 2018. So the other one to watch is the yellow gold line, which is synthetic opioids. And that includes tramadol, pethidine, fentanyl, and would also include nitazenes, which Hester mentioned, that a very potent group of illicit opioids that has sporadically appeared in recent years and might become more visible in the data in the years to come though of course, let's hope it remains just a sporadic presence. So to close out the discussion of unintentional drug-induced deaths, I just want to remind the audience of something many of you know, but might have gotten a bit obscured in the discussion of these individual drug types. Most unintentional deaths involve more than one drug type, so they are polysubstance deaths. So opioids and benzodiazepines are by far the most commonly found substances in deaths that include multiple drug types, right? So of these polysubstance, so about 70% of unintentional drug-induced deaths are polysubstance deaths. And of those, almost 80% involve opioids, and almost 2/3 involve benzodiazepines, right? And so the presence of those two drugs, so prominently, it illustrates the risks associated with drugs that induce respiratory depression. One somewhat interesting thing is that there is a different age distribution in these polysubstance deaths. So male polysubstance deaths are more likely to be recorded among younger cohorts. So about 40% of polysubstance deaths among men occur in people 20 to 39, whereas it's actually the opposite in females. 40% of polysubstance deaths occur in people aged over 50. So there are some discrepancies that you see across the sexes, according to the data. Finally, I just want to note that the report focuses on fatal overdose, but it also includes a non-fatal section looking at drug and alcohol-related ambulance attendances and hospitalizations. Unsurprisingly, alcohol dominates both of those categories, but there are some emerging trends to watch with respect to drugs. One that might be on some people's radar already is the rise in GHB ambulance attendances, which rose about 70% just between 2021 and 2023, including a tripling of the rate of attendances in Queensland and a sharp rise in Victoria, where these incidents occur at the highest rate by far in Australia. So that's a brief snapshot. There are many more breakdowns in trends across jurisdictions by drugs and drug types, about polydrug deaths, about drug-induced suicides, and non-fatal trends as well that can all be found in the report, which is available to download from our website. Thanks so much for your time.
Thanks, Jake, and perfectly to time too, might I add. That's fantastic. We have quite a lot of banter in the chat. Jake, one of the first questions we were asked, I might kick off with this, was do we know how many people have died from overdose or experienced an overdose over the past weekend? And I wondered if it might be worth an opportunity just to point out the effort it takes to collate this kind of data, and certainly to do it rapidly, and just reflect on the fact that this is 2023 data that we're looking at in 2025. And wondered if you sort of had any comments related to that, or what might be needed for timelier responses.
Yeah, I mean, I would, yeah. So we are very thankful to our partners at the Australian Bureau of Statistics who get us this data in beautifully sort of digestible form, at least for us, to put together the report. So a shout out to the ABS crew. But yeah, I mean, as I mentioned, it takes a lot, right? So the deaths occur, a coronial investigation occurs in many cases. That has to be done. It has to be finalized, certified. Then the state and territory governments are collecting it. Then it gets compiled and goes to the ABS. So the time lag does add up, and it would be great to have a more, a sort of faster system of certifying those deaths and certifying, drug-related deaths and being able to compile that information. That would be a little bit more useful in terms of like early warning and early monitoring systems. So the US does almost everything wrong on drug policy, but they do actually have quite timely gathering and monitoring of the data on drug-related deaths. And so actually we might be able to learn, until the CDC shuts down that website, as they're shutting down all their other operations, we might be able to learn a little bit about how to move more rapidly there. But you are pointing to something important in terms of timely data. So one thing is the timely sort of finalized reviewed data. Another thing is timely monitoring of like dangerous things that are circulating in the community, right? And so Australia, a number of states have developed sort of monitoring systems and early response, prompt response network and hospital monitoring and all these things. And we are getting better, but we still also have more work to do to be able to share that data across jurisdictions and be able to move quickly to integrate data from various sources so that we can get information about dangerous substances distributed across the community.
Great response. Yeah, we can't really know at the moment unless it makes it to media, or we do have a localized monitoring system. And I would just point out too that as wonderful as it sounds to have a national monitoring system that's rapid, it is a really complicated thing to put together with a federated kind of model that we have here in Australia. However, the US are doing a fantastic job. Thanks for that, Jake. Hester, I want to throw to you before I come back to more on national kind of strategies. And you mentioned one way to support GPs sort of to be able to maybe more confidently or proactively counsel and sort of monitor for risks, or ask about drug use first and then maybe counsel and monitor for, substance related risks in patients, could be to have peer workers. And I think that's a fantastic idea. And I was just wondering, is that a model that's happening somewhere? Is there any kind of data to show the impact either on patients or GPs? Probably not.
No, look,
Yeah.
but I just think, so certainly I'm from New South Wales, and we have the New South Wales Users and AIDS Association, and they have peer line. And the idea that I, as a general practitioner, could ring up the peer line and go, hey, look, such and such. Or the other thing that does happen is that peers will ring peer line, who will then liaise on behalf of that person with their doctors. So it does kind of informally happen. But I guess it's that thing for me of how fantastic I find it in my public work, having peer workers, and how fantastic it would be to have that in the general practice setting when you needed it. So, dial a peer.
Yeah, I love that idea, and I think actually you nailed it. I think our peer organisations punch well above their weight in terms of the advocacy that they do and the roles that they can play. And there are a lot of things to consider around. You can't just pull somebody in and call them a peer, and there's a lot of sort of workforce things you need to put into place to make sure that peers are well looked after in a workplace.
Absolutely.
So I'm just going to mention that too. But what a fantastic model, and potentially there's an opportunity there, because another comment in the chat was sort of around anxiety about disclosing information that could be electronically recorded in a medical record, and then there's a risk of a data breach, and that information is out there, and I understand there's patient protection rights in terms of what a doctor can disclose, but maybe that's one of the ways around some of those, breaking down some of those concerns even.
Some of the concerns, but those are concerns that GPs have as well around, I need to be really careful what I write. So something that we're really aware of, this is such a tricky thing, because on the one hand, if we hide information, it makes it special and different and kind of cements stigma. Whereas if we make this boring every day, I'm not saying that drug use is boring, but the issues that you have, just like you might get diabetes, or just like that it's just a boring medical issue, and having it just is part of your record without it being special is an important shift. But I also acknowledge that that's not the state that we have now. But certainly what we saw, and this was particularly with the GP training, was the ability for GPs to self-reflect on that and go, actually, I'm going to change the way I do this. I'm going to change the words I use. I didn't realize that this was going to impact people, and they're my patients. I care about them. I want the best for them. And so I will, we are patient advocates. That's what we do very well in general practice, and we will change if we need to get the best outcomes for our patients.
Amazing. Yeah. And I think that's a good thing to remind people of, often some of the stigma that, whether it's coming from GPs, whether it's coming from, somebody up the community at the local shops, wherever it's coming from, or in the school or the workplace, it's often inadvertent. It can be quite intentional, but generally it is inadvertent, and it's having that communication, I guess, being to give the opportunity to reflect on maybe how we write our case notes or whatever it might be. I'm going to stick with you because I had another question that popped up, Hester, in terms of sort of, do you have any comments on sort of beyond prescribing or beyond sort of asking the questions and having naloxone in their toolkits? What are ways that GPs might be able to contribute to sort of post-overdose care pathways or that sort of thing? And maybe as a sort of half follow-up to that, if I can throw it all at you at once, are GPs aware about the take-home naloxone program and able to refer people onto it, but sort of beyond just getting naloxone into people's hands?
Yeah,
to add there?
absolutely. So first of all, coming back to post-overdose, so if somebody, and look, non-fatal overdoses are a real issue as well. And the impact that potentially that could have on your brain function is really important. But one of the things that happens with overdose is if people get to hospital, what we need is a discharge summary. And so there's been a lot of work in this space to ensure that we can get discharge summaries, and there's more work to be done. But a discharge summary that very clearly lets the GP know what has happened and what needs to happen as a result. And if as a GP I get that and I know that's happened, I can call my patient, I can check in with them, follow them up. The other thing is if tragically someone dies, quite often we don't hear. And the first we hear of it is when a family member rings us and lets us know. So we've got our own kind of emotional response to hearing that someone that we cared for has died, but also we're supporting the family. And we're incredibly important in terms of supporting the family. And I would flag, it's not just me as the doctor, it's our nurses, it's our reception staff, because we all have these ongoing relationships. And certainly with one particular case that I recall very, very clearly, that our front desk staff were incredible in terms of supporting a mum who'd lost her son to an unintentional overdose, and they were just incredible. So around that emotional support, but also around, we really want to make sure this doesn't happen again. And what are the other things that can be put in place? So yes, the naloxone, the take-home naloxone, and making sure that families and carers and friends have it and are not afraid to use it, and know, call 000 and give the naloxone and wait with the person. But also, don't use alone. Let someone know that you're using. And what is driving use, and being careful around what it is that you're using, because you want to have fun. But if it's actually to help you manage your distress, then get help for that distress. Now, there was something else you had in that question. I don't think.
No, I think you covered. I think I asked about the take-home naloxone, but I mean, obviously, it's just making sure that people are aware, and it comes back to communication, right? The GPs being confident, having that conversation, being able to say to somebody, look, if you can't not use alone, have you got someone you can call? Is there a hotline you can reach out to? It's that communication and just making a safe space for people to talk about overdose or drug use specifically in the workplace and elsewhere. And we're getting there. I think we're slowly getting there.
Yeah, and look, we've done a lot of work in the college raising awareness amongst GPs. So News GP, which is the newspaper that most GPs read. We've had lots of articles in that. We've had papers. So we really are working with GPs around. This is super simple. All you need to do is tell the person, go down to your local pharmacy. You don't need to give your Medicare number, don't need to give your name. You will get it for free. If they don't have it, you can ask them to get it in.
Fantastic. That's a good information. We've had quite sort of moving on from specifically GPs. Sorry. Do you want to add to that, Jake?
Jump in? If you mind, I was just going to extend sort of the logic of how to get action from different parts of the community and Australia. So I just think I just wanted to make sure we get a chance to call for action across all different domains before we close out. And so I think talking about naloxone and take-home naloxone is a good opportunity to sort of mention the different roles for different actors, in society, right? So, just people, everyone has a role to play in helping prevent overdose and helping to deal with potentially seeing an overdose. And naloxone is the clearest example of a way that everybody can help. Everyone can be prepared. GPs also as members of the communities they reside in and have a very important role to play. But let's not forget about governments too, at multiple levels. So state governments are the main sort of locus of action for a lot of drug policy. And one thing that state governments, where there's been sort of some dabbling and also some divergence between the states and territories, is drug checking or pill testing. I'm glad to see in Victoria here that the first permanent Victorian drug checking service opened less than 2 weeks ago here in Melbourne, so that's great. Canberra also has a permanent drug checking service, but other states and territories do not. Queensland dabbled, but then sort of retrenched. And so what we really want to see in terms of talking about the toxic drug supply, particularly in the illicit market, nitazines we mentioned, there's also novel unregulated benzodiazepines that are in circulation, wide circulation. If you buy Xanax on the street, it's likely, so-called street Xanax is likely to contain compounds that are not Xanax, that are more sort of dangerous and unpredictable substances, and that's handled at the state level. So we see states having a very important role in pill testing services, potentially supervised consumption sites, things like that. And then the federal government. So the federal government has been very useful in instituting the take-home naloxone program, and also in a couple of years ago in expanding the people's ability to get pharmacotherapy drugs, so opioid dependence treatment drugs, methadone and buprenorphine, without having to pay daily dispensing fees. But since then, there has not been as much action at the federal level. And so we'd really like to see more energetic action at the federal level, including a national overdose prevention plan, and potentially a sort of reconvening of the Ministerial Council on Drug Strategy, which used to serve a very important role in agenda setting, right? In getting drug policy a prominent place on the agenda by bringing together all the relevant health and justice ministers from the states and territories and the Commonwealth. So we've got community role, we've got state and territory role, and a federal government role, and it's going to take action from all of those entities and all of those people to really get sustainable progress on this issue.
Thanks, Jake. You actually read my mind, because that's exactly the segue I would have wanted to do, but you did it far more articulately and smoothly than I would have. So I really appreciate that. Yeah, absolutely. I just want to point out two things off the back of that. One, yes, the naloxone conversation is a great jumping board and a trigger point, but it's not the only conversation we need to be advocating for. And I think you've really covered some of the bases there nicely. I'd also like to say that I noticed on the weekend the Queensland Drug Checking Service have actually announced that they've reopened. I think maybe I'm not sure for how long, but just shout out to Queensland there. And I guess you've already touched on this, but in terms of a national overdose response, there's been a lot of comments in the chat. We thought we had one. We did used to have one. It lapsed. It sort of fell over. It hasn't been picked up again. I think we've really stressed that we do need some sort of national coordinated response, even if it's just facilitating the conversation and the agenda. Do you have, and you've sort of touched on what some of the pillars of that could be as well. But what avenues, resources, like how do we get government interest and action to sort of push that forward again? Sort of what can people on this call do, even as, everyday human beings just living their lives, sort of push forward for that agenda? Jake, I'm going to throw to you first. The big question.
People just need to, it is a political issue in some ways, like many others. It is a more challenging political issue in some ways, because politicians certainly would rather sort of ignore it as much as possible, just because it is substantively difficult to deal with, but also drug use remains quite stigmatized, and people who die of overdose remain stigmatized, and people who use drugs remain stigmatized. So it is it requires a lot of sort of vigorous pushing at all levels to get it on the policy agenda. So we just want people to make sure their voices are heard. And of course, we at Penington Institute like to help. We're always welcome to ideas. So we're always interested in hearing ideas from the community about how to engage policymakers and actually get things moving.
Amazing. Yeah, and Hester pointed out sort of the anxiety that GPs and the reasons, the legitimate reasons why GPs might have anxiety about sort of talking about drug use. That's sort of, exacerbated at a political level, why it's a bit of a taboo and a no-no. So write to your local MP. If you've got ideas for campaigns, reach out to those around you. We're all in this together. And I think that's a really nice note to wrap up on, which is good because we are almost out of time. Look, I really want to thank you, Jake, for the tireless work that the team have done getting this report together and putting together a little summary so succinctly, and encourage everybody to jump onto the Penington Institute website to download a copy of the report. We definitely welcome comments and questions and feedback. And of course, to you, Hester, for taking time out of your day to join us and give us such a wonderful and impassionate presentation and a bit of a call to action and a bit of an understanding of what it's like at the GP side of the fence. So thank you so much for your time as well. It's been really wonderful to be able to have this conversation. It's never long enough, obviously. But without further ado, we are at 3 o'clock, so I will wrap up. As I said, we always welcome questions or feedback, so please do reach out. If any of you are still observing Overdose Awareness Day over the coming days, be sure to schedule some downtime and look after yourself and your communities and the people around you and the people you work with. We all look forward to seeing you online or in person, hopefully again soon. If you have any feedback, stick around and fill out the feedback form. But otherwise, bye for now and enjoy the rest of your week. Thanks so much for joining us, everybody.
Thanks, Rita. Thanks, Hester.